Welcome to this evening's meeting of the Health and Social Care Review Group. Start off with the administrative stuff. This evening's meeting will be live streamed to the public. A recording of the public past meeting will be available on the Council's website in 24 hours. If remote participants can use the hands up icon on your screen for questions and comments, and make sure your camera and microphone is on when speaking and off when finished. And people in the chamber, members and officers, please remember to switch the microphone on when speaking and off when they're finished, and speak directly into the microphone. Please switch off mobile phones or place on silent mode. The agenda, apologies for absence.
Yes, Chair, apologies from Councillor Pitts.
Thank you. And minutes of the last meeting, 23rd of November, are those okay? Thank you. Thank you. Any disclosures of interest?
None that I'm aware of, Chair.
Any urgent business?
None, Chair.
References from committees or other bodies?
Again, none, Chair.
I have nothing to report on from them since the last meeting. So if we go to agenda item 7, update on the provision of NHS dental services in Luton. David, I believe.
Yes, hello Chair, David Barter, Head of Commissioning NHS England.
Please go ahead, David.
Certainly. So thank you for the invite for this evening. I'm expecting Tom Norfolk, who is our local dental network chair and a practicing dentist. He was going to try to join remotely as well. And so if he's in the lobby, if somebody could let him in, that would be great, electronically. I take the paper really as read, Chair, if that's okay, and happy just to field any questions that any of the committee would have.
Okay. Does anyone have any questions or comments on the report? Yes.
Healthwatch did some research on dentists 3 months before Christmas. Most dentists in Luton were not taking on new patients and were saying that we're at full capacity and actually were finding it quite difficult to employ new dentists. Can you comment on that? And so if a new patient wanted to come to the dentist, they would have to pay as a private patient, not an NHS.
Certainly. So I can't comment on the private aspect because NHS England, we don't commission the private aspect of dental practices. We acknowledge that there is a backlog caused by the pandemic of dental treatment. So many dental practices that have regular patients, because there is no registration with a dentist, are obviously have an obligation to see those patients and to try to take on as many other patients as possible. But we're still experiencing the effects from the COVID pandemic and its subsequent backlog. I see that my colleague Tom, Chair, has just joined me. He introduced himself.
Hi everybody, sorry I'm late, I was waiting to be let in. So my name's Tom Norfolk. I'm a dentist, a clinician, a few days a week, and the rest of the time I work with NHS England as chair of the local dental network, which advises and supports NHS England on a clinical matter, and that includes Luton. Good evening, everybody. Nice to meet you all.
Okay, can someone address the question, or if that's possible.
Chair, I thought I had addressed some points to the question, in that because there's no registration in dental practices, unlike GP practices, patients can seek treatment from any dental practice that has an NHS contract. And we have quite a number of practices that have those contracts. We ask the contract holders to try to keep available slots for patients that have urgent care or higher needs, so that when they're approached, patients can call NHS 111 for assistance to find dental practices or search them themselves. Practices are independent providers, and depending on their workload, will kind of open and close the ability for new patients to start new courses of treatment, depending on the practice's respective workload.
Thank you, sir.
Can I just add, we phoned every dentist in Luton on numerous occasions, and none of them were taking on new patients on the NHS at all. Not across Luton, no dentists.
And we would encourage actual patients to continue contacting practices. Many practices will keep a sort of waiting list, and they will also ascertain the clinical need of the patient as well. If a patient's calling just for a regular checkup, they may expect to wait a little while. If patients have dental pain, swelling, we would expect an NHS practice to try to slot them in. And perhaps Tom could talk to that in terms of what we ask our providers to do.
Yeah, happy to, David. So it's essentially, as a practices, the capacity or the ability of practices to accept new NHS patients varies on a day-to-day basis, through lots of reasons, particularly at the moment, having just with my own practice, just dealing with a dentist who can't come in tomorrow because they've got COVID. And that's on the back of a couple of staff last week who had COVID, and sort of a combined flu that seems to be going around. So the capacity within practices has varied throughout this last sort of year to 2022. And thinking back to it, we started off really just pulling out of the winter, Omicron and that sort of thing. And we haven't really got ourselves onto a square footing yet. We've still got a lot of backlog. The patients that a lot of us saw during COVID and during the lockdown and the difficulties were increased high needs. And a lot of publicity has brought out patients who don't normally visit the dentist very often are coming to see us, and they've got a lot of additional needs in that they've got a lot of decay, a lot of gum disease, and that's taken us longer to treat them. So we find these patients are taking us longer to get through the system, which is clogging up our normal systems. So we haven't got the capacity we want. Most practices, certainly all the practices I know, run some sort of a waiting list, either formal, informal, depending on how big it is and the need. And they'll often pick patients off based on the highest need, as David said. So if someone's in toothache, they're likely to get seen sooner than somebody who, say, wants a new denture. And that's just how it goes at the moment. A lot of practices are prioritising children, particularly because they were one of the designated groups of increased priorities, and children in pain particularly. Some of our hospitals are struggling with dealing with children that have got a lot of decay that need a general anaesthetic. You've probably heard in the news, it comes around every so often about children needing a general anaesthetic for decay. Has been sort of very high, and it is in Luton and in that part of the region. And the problem is that there isn't a great deal of theatre capacity. Theatre capacity is very limited within hospitals at the moment. They're all struggling through various reasons. So what we want to do is make sure that the decay in children's teeth doesn't get so bad that they need to have a general anaesthetic. And so we're managing a lot of those sort of difficult cases within practices, because of if we send them into hospital, they're just going to sit on a waiting list because of the difficulties there. So, and you listen to the news, I'm sure, like everybody else. So most practices are dealing with a lot of increased demand for their services, and that's really gone off the scale. Something that I haven't seen for as long as I can remember as a dentist, and I've been a dentist for a long time. Well, feels like a long time. So, don't know if that helps. I'm happy to answer any detailed questions and get into the nitty gritty if you wish.
Yeah, thank you. So, just to clarify, there's two different capacity issues. There's the point that's just made about signing on new NHS patients, but there's also the day-to-day capacity issues that you're having, and the day-to-day issues there are impacting on the capacity to take on new patients. Is that correct?
It is, Chair. Yes, it's like most of the NHS, it's run along. It runs at a comfortable level, but as soon as little things can really knock it offline, and then they have individually knock-on effects. So yes, there are those patients where they're already in our system, and so a lot of practices, and I know quite a lot of practices in Luton, really stepped up in the pandemic and opened their doors to large numbers of patients, and those patients still have got outstanding treatments we're trying to get through. Now that might seem a bit sort of odd if you go to the dentist regularly, because you probably have your treatment done in 1 or 2 appointments. But for a lot of patients, we need to see them repeatedly over 6-9 months, several appointments, long appointments, and that makes a difference from a quick sort of checkup or a quick checkup and a filling, which some of you may have experienced, to sort of patients who are spending hours in the dental chair. And so if you think of one patient taking 6, 7, 8 hours to treat, that's a whole day, and the knock-on effect to other patients. So yes, there are these effects. You're absolutely right, Chair. And the other effect we have is that there's difficulties with the workforce. We're not immune to the general difficulties of recruitment that businesses have out there. We're recruiting dental nurses from the sort of general pool of sort of the population out there, but also we're trying to recruit dentists as well, and there's a real shortage of dentists across the country. That's nationally recognised. It's difficult to recruit, and I know some of the owners of practices in Luton. I know them well, and they really struggle to recruit to fill vacancies, and that means that instead of having 4 dentists, you've got 3 dentists. Well, you're down 25%, and then if you add in all the things I've already said, there are real difficulties with that, and the capacity that practices have does vary from week to week. We've also seen massive amounts of illness, massive amounts of disruption that we haven't seen before for years. So all of that just combines. I don't know if that answers your question in enough detail, Mr. Chair, but happy to go into further detail on any matter if you wish.
Thank you.
Sorry being late. Sorry, Chair. My concern is that I've met patients who are really suffering with very bad toothache and cannot get appointment with any dentist to try and solve their problem, and they're having to go to work in absolute agony. This is, as far as I'm concerned, it doesn't seem acceptable. Are we still working under the old contract from the last Labour government due to dentistry?
Maybe I could answer that, Chair. So the contract that we work to is the 2006 dental contract, which is starting to be reformed, and there have been some interesting changes that we can brief you about maybe a little bit later. So yes, practices still work to that blended system through that 2006 contract, where you have a band 1 or a band 2 or a band 3 course of treatment. And unfortunately, those banded courses of treatment, the remuneration to the dental provider is kind of not in alignment with the chair time that it takes. With regards to patients that are in pain, nobody would want that at all. We suggest that patients that do have pain call NHS 111 or NHS 111 online to seek help to source dentists that have urgent slots. And during the period of time, you've had a couple of practices within the Luton area that have acted as urgent dental centres. And so what that means is they become first responders on the DOS system, which is the NHS Directory of Services, so that if a patient contacts 111, that should signpost the patient if their needs are high enough. And if these are patients in abject pain, then their need is high. They should be being signposted into one of those urgent dental centres or other practices that have ability to see patients.
I mean, I'm not too bad. I have a dentist where I can go to, and I've been in there, and people are trying to get appointment, and they're telling them 1 year. I mean, is this really acceptable? That people are being told they can't even get a dentist to look into their mouth to see what's wrong with them for 1 year? Is this really what we're here for? Surely this is not acceptable.
Well, the appointment time would be clinically managed, and maybe I could invite Tom again to talk to how practices are required to clinically manage that situation.
Yeah, so you're absolutely right, David. Because of all the things that we said, the managing need, demand, importance of clinical criteria, whatever you want to call it, becomes increasingly common, compared to 20 years ago when it was perhaps easier and a lot more dentists working within the NHS. Now that the demand is higher, and so what we do is we actually, when we see a patient and we say, okay, you need to come back or we need to see you again, then in actual fact, we'll actually book up to 2 years ahead. So we'll be saying to patients, we don't need to see you for 2 years because your mouth is so good. For some patients, we'd like to see them next week, and for other patients, also, certainly within a few months, but for others, it's variable. So gone are the days of the 6 months routine checkup and that sort of thing. We're encouraging patients to come according to their dental health and what we think. Now, the idea is that then we sort of say to them, look, we don't need to see you for a year or come back in whenever. Some of the patients actually want to come back in 6 months. Some want to come back a lot sooner. And that can lead to a little bit of discussion and disagreement about when you need to see them and when they want to be seen. And giving that reassurance that they can get back in, particularly if you've seen them recently, to come back if there's a problem, is there. But we do sort of risk assess all our patients, and the guidance we use is something called NICE, National Institute of Clinical Excellence, or Health and Clinical Excellence as they call themselves, and they have pretty clear guidance, and we're encouraged by NHS England, both regionally and nationally, to follow that sort of guidance with regards to when we see patients, how often we see patients, and that just helps to try and sort of smooth the capacity and make it easy for patients who are in pain to be seen. And as David said, the pathway is through 111, and many practices like myself and many practices in Luton, and there are some practices done an awful lot of hard work in Luton, have really stepped up to the mark, and they've seen large numbers of patients in toothache through the 111 system. Now, again, that capacity varies on a daily basis, but it is there and it does work. But it doesn't work perfectly every single time, like most things in life.
Thank you. I think, Mark, do you have your hand up?
I do, Richard, yes. If I could just ask a quick question. I mean, sort of rounding some of this stuff, I just wondered when I was looking, struck me when I was looking at the report, have we got anything around the number of patients prior to COVID, during COVID, and where we are now?
That's a very good question. We don't keep The individual practice know the numbers of patients that they see. What effectively happened during the COVID pandemic, for a while, dentistry was almost closed, and you would call the dentist and be given, painkillers, prescription over the phone effectively. And then contract holders were then allowed for a time to deliver 20% of their contract. This was due to infection protection control protocols to keep both the patients and dentists and their teams safe. So you went from a scenario pre-pandemic where you'd have lots of patients waiting in a waiting room, just seeing a dentist, to patients waiting in their cars, being called in, having their treatment, and in some cases, the surgery then needed to lay fallow for up to an hour before being cleaned prior to bringing the next patient in. So the numbers of patients seen was incredibly low. We would expect an NHS dentist to see anywhere between 25 and 30 patients a day, depending on the experience of the clinician. During the pandemic times, it was probably only a dentist would probably see 5 or 6 patients in a day because of the fallow time and infection protection control. That now has changed. Since July last year, practices are meant to and try to deliver 100% of their contractual activity. It's still difficult because there is still all of these bugs floating around, and we need to ensure safety of patients and the clinical teams. Because you don't want your clinical team to become sick and then there be no provision of services for a few days. But the numbers we don't record. Our consultants in dental public health would have ability to mine those figures. So I could ask them to do that, and we could send you some figures post this meeting.
Yeah, I mean, if scrutiny are in agreement, I think that would be helpful to understand, isn't it? So what we're trying to find out is the trends of prior to COVID, and David completely understand the beyond challenging time of COVID and where it was and the impact of that. But I think the here and now, so before COVID and to now, I think would be really useful. I think within the room we spoke about potentially people waiting to become. So I didn't know if there's waiting lists as well, if there was something that could be shared potentially. And again, I'm not looking for an answer now, but maybe that's something you could take away. And just from us with regards to the number of appointments, as you say, actually, if you haven't got patients, that's the appointments, to give us a feel for the amount of people using services. I think that would be useful for scrutiny to understand.
Certainly, if I may just come back on that, I definitely can get our consultant in dental public health to provide some figures in terms of patient attendances into NHS practices. In terms of we can get back to you after the meeting with regards to that. So thank you.
Yeah, thank you. That'd be very useful. Thank you.
The pilot program was completed. When the evaluation is likely to be shared?
Did you get that?
I'm afraid I didn't quite hear that, Chair. It was very faint.
Yeah, the pilot program was completed, I think, this year or last year. This year, and the evaluation is still awaited. When that is going to be completed or shared?
Thanks. Perhaps Tom, did you want to talk to that?
Sure, yeah. So that was, I think, Chair, that was the pilot and when the evaluation is going to be shared. And was that the pilot for urgent access you were referring to?
That's why I said the urgent access.
When it is likely to be shared?
Sure. Yeah, that's and you're referring to the urgent access. We've got several pilots on the go, several proposals, and we're trying out various things. But with regards to the urgent access, so what we've done is that's now coming to the end. We've got an evaluation group that's meeting on Monday to start to sort of pull some of the data together. We've got a variety of data from different sources. We hope to have that done by the end of this financial year, so the end of March, which will then go forwards to the integrated care boards and give them the opportunity to look at that. It is that the evaluation takes sort of two forms, I suppose. One is objective data, and the other is sort of more subjective soft intel. And I think that I can give you a sort of sneak preview of the soft intel if that's what you're wanting. And I think the soft intel is that it was well received. The idea that we can move outside the system, the units of dental activity based system that David has referred to, that the contract has, which doesn't really work, and everybody, national groups, patient groups, everybody admits it doesn't work. And we can start to look at a different way, and that in itself is popular, because UDAs, or units of dental activity, are very poor at addressing how we deal with such patients, particularly high needs patients, and we know there's a lot of them there. And then the other thing that's favourable with regards to that is that how do we link then prevention and stabilisation? Because a lot of these patients, some patients have just got a tooth that's broken. It's very simple. There's nothing else in their mouth. They're generally well maintained. But a lot of these patients have multiple problems. They've got multiple dental problems. And often we know that dental problems link with health problems. And so prevention and stabilization are really important. And it's something we've trialed. It's something that David and myself and a few others have been working on for a long time, and we've led the country in this. And there are some national changes coming through, but they're slow. We've done quite a lot of work before that, and so the evaluation there would be that urgent care, with, if the patient wishes, a follow-on of prevention guidance. Sugar equals decay. Smoking's bad for you. Brushing your teeth helps to prevent gum disease and tooth decay. All that sort of information and guidance and support in a constructive manner. We know it's evidence-based. We know it works. Combined with stabilizing all the other decay and disease that a lot of such patients have, and taking them through a multiple phased courses of treatment, is a very popular way. And so the soft feedback we've got is that our dentists like that, our dental care professionals, so nurses, therapists, and the wider skills mix work with that. And I think so as clinicians, we like that. And I think David, as commissioner, and him and his team like the way that we're addressing patients that need it the most. So I think the feedback will be that this is popular from everybody. It needs a little bit of fine tuning, but we've done all the hard work. So that, I suspect, that will be the evaluation, but we will have formal data which will eventually be shared with the ICBs and will be written up, I'm sure, in due course. I'm not so sure how that's shared and how that's passed around, but I'm sure it'll be the ICBs will have that information in due course, I'm sure. David, I don't know if there's anything further you'd like to add in relation to that, because I know we've worked a lot on this sort of thing, haven't we, for a long time. So
if I may, Chair, come in. Thank you, Tom. Yes, we've run that pilot for some time, and we are in the process of evaluating it. The information that we've gleaned of what parts are most effective for patients, what parts are most effective for continuing care of patients, we will be linking and are linking very closely with colleagues in the ICB. They become delegated commissioners for dental services as of the 1st of April this year, 2023. And so we're in the process of handing over information regarding commissioning and many of the pilots that we've run, how they actually benefit patients and make a more streamlined care system as well for patients. And then the ICBs will be able to continue that work going forwards. Thank you, Chair.
Thank you. Anyone else? Okay, thank you very much. We look forward to getting the pre-COVID comparison data, and presumably that any future reports will be coming from the ICB.
Post-April, Chair, yes, it will be colleagues in the ICB.
Okay, thank you. Okay, if we go on to item number 8, Luton Tobacco Control Strategy. Serena, I believe.
Thank you, Chair. Good evening, everyone. I do have a slide deck to share if possible, but at the moment I'm not able to on Teams. I'm not sure if it's because of the permissions. If it's going to be tricky, don't worry. I'm happy to give a verbal update, but if possible, that'd be appreciated.
Okay, looks like we're just trying to get that sorted out now.
Thank you. That seems to have worked. Thank you very much. So hopefully you can see them slides now.
Yes.
Perfect. Thank you. So good evening, everyone. My name's Serena. I work in the public health team at the council and just wanted to give a quick overview of the tobacco control strategy that we've been developing over the last 6 months in conjunction to the report you will have received. So I firstly just wanted to highlight where we are in terms of tobacco prevalence in Luton at the moment. So as you can hopefully see from this graph here, generally between 2011 and 2021, there has been a decline in tobacco prevalence at not only a local Luton level, but both at East of England and England level. But as you can see here, our blue line, which is Luton, indicates quite an erratic picture in terms of prevalence. So particularly here, you can see between the years 2017 and 2020, Luton actually started to experience an increase in tobacco prevalence amongst our 18 plus age adults, whilst in the east of England and England, the rates were actually starting to decline quite steadily. So I just wanted to highlight that as a real case for action in terms of really investing into some long-term and sustained and strategic work around tobacco control, just to really try and drive our rates down in line with the east of England and England moving forwards. I also wanted to highlight that smoking still does remain the leading modifiable risk factor responsible for health inequalities. So in Luton, this translates to approximately 191 people that unfortunately die each year as a result of smoking, which is of course entirely avoidable. So we are aware also in Luton that we have a number of particularly disadvantaged groups within our population that actually have a much higher smoking prevalence than the general population. So this includes individuals who have routine and manual labour work, also those who live in social housing and those who suffer from mental illness. So it's actually estimated that as approximately 4,000 households in Luton that actually live below the poverty line when smoking costs are taken into account. So that translates into over 9,000 adults in Luton that are living below the poverty line after smoking costs and 4,000 children. So I just really wanted to highlight that as by tackling tobacco control, we're really making strong links with our Luton 2040 agenda of trying to see nobody in poverty. So as well as having a detrimental impact on individuals' own personal finances, it's estimated actually that Luton's wider economy, tobacco costs about £60 million per year. So as you can see here, the large proportion of this is actually lost through productivity. So that's money lost via earnings, unemployment and early deaths related to tobacco. But there are other causes as well. So just over 8 million lost each year on hospital admissions and primary care, treating individuals who have tobacco-related illness or disease. Looking later in life, there's about 3.6 million lost each year to our local economy in domiciliary and residential care, caring for individuals in their later life. And just over 1 million each year is lost through tobacco-related fires. So where we stand at the moment is that Luton doesn't currently have a tobacco strategy in place. The latest one that we did have expired in 2015 and has since not been updated. I'm sure colleagues will be aware that we did actually, or were expecting, a national tobacco strategy to be released by government last summer. However, that has been indefinitely delayed. So rather than waiting for that, we wanted to be proactive in making a case for a local action. So what we did first was review our local prevalence data that we had available to us, which really allowed us to try and understand some of our key priority populations who are experiencing disproportionate harm from tobacco use in Luton. We also worked really closely with our Tobacco Free Luton Alliance to map what activity is already going on across the whole system in regards to tobacco control, and then more importantly, identify where the gaps were so that we could really use this as a backbone of our strategy moving forward. So with Tobacco Free Luton at the heart of this, we worked quite hard to review the membership and tried to really expand that. And as a result, we've got much greater representation now from stakeholders across the whole system that have a vested interest in tobacco control. So with them, we've created this draft strategy, and there is a robust action plan that also sits alongside that. And that's where we are at the moment. So the strategy itself, the main vision really is that we want to see a tobacco-free Luton where our communities do not suffer from the harms of tobacco use and where people lead ultimately healthier and longer lives. So we have one key overarching aim, and that's to reduce our smoking prevalence in our adult population from 14.1%, which is the latest figure available to us in 2021, to below 10% by the end of the strategy duration in 2028. So we've picked this aim based on an ambitious but we feel achievable and attainable 1% reduction in smoking prevalence for each year of the strategy's duration. And that will really help to bring our figures and prevalence right back in line with our East of England colleagues and neighbours and the national trends. So as well as having that overarching aim, we've also want to make sure that we're focusing on some of them high priority groups that I mentioned. So as you can see here, just as an example, we've also got some prevalence that we'd like to achieve for routine and manual groups and social housing, but it's not limited to that. So just to briefly touch on some of the strategic priorities that underpin our strategy. So we've picked 6 key themes. So first, we want to make sure that we're really working in partnership and adopting a whole systems approach to tobacco control. We want to work really closely with our children and young people and adults in Luton to try and prevent the next generation of smokers. For individuals that are smoking in our communities, we want to make sure that we offer them every support possible to try and quit and that they're aware of what that offer is and how they can access that. That will also be helped through effective communication across all of the lifespan and age groups, just to try and help people understand the harms of taking up tobacco, and if they already have, how they can get support to quit. A new and more emerging picture actually is around tackling illegal products. So we know we have a presence of illicit tobacco, vapes and shisha in Luton at the moment. So we're going to be working closely with our trading standards and regulatory teams around tackling that in a bit more detail. And then finally, we want to work on promoting some more smoke-free environments and policies across the town. So working really closely with our partners to help them adopt healthy workplace policies, for example. So in terms of our priority groups, which I've already touched on a bit, I just wanted to highlight all of them. So we've obviously got children and young people, as well as the prevention arm. We're also seeing an emerging trend of young people taking up vaping who aren't necessarily smokers or haven't smoked before. So we're really keen to work on that within that priority group. We've also got our routine and manual workers. We've also identified that social housing and other private renters and social housing tenants are particularly at a greater risk of taking up smoking than other population groups. We're working closely with our NHS colleagues to deliver the long-term plan, who are directly supporting individuals accessing acute mental health services to treat their tobacco addiction. We also want to work really closely with pregnant women, and finally our Eastern European communities and ethnic groups, as we anecdotally are aware that there is a higher prevalence of smoking within them groups also. So we've been fortunate to secure some funding to deliver the first 2 years of the strategy, and at that point the ongoing funding commitment is going to be reviewed. But as I mentioned, we do have a really robust action plan that sits behind the strategy. But I just wanted to give a very high level overview for the purposes of this meeting tonight on some of the activities that we have planned and are making plans for and have already started. So as you can see here, all the activities that we are trying to do, we're making sure are evidence-based and are aligning to one of our 6 key strategic priorities. In terms of how we're actually going to measure success of the strategy, so there are a number of key performance indicators that are related to tobacco control, and a lot of these are already routinely available to us via the Office for Health Inequalities and Disparities, so previously Public Health England. So as you can see here, we routinely collect information on that adults prevalence, but also priority groups, including those routine and manual workers, individuals who smoke at time of delivery, and pregnant women also. We also collect information on children and young people smoking and vaping habits, both regionally and at a local level via our SHU survey. And as you can see there, we also have data available to us on attributable mortality and hospital admissions related to tobacco in Luton also. And as well as that, we commission our local stop smoking service, currently Total Wellbeing Luton. So we work really closely with them to get a feel for the type of referrals that are coming into them and help strengthen them referral pathways in. But we can also see the actual successful 4-week quits that the service have achieved. And then finally, we can also keep track of the type of community engagement, clinics and outreach that the service are providing, trying to reach into those high priority population groups. So the strategy is going to, moving forward, be delivered by Tobacco Free Luton. So the group meets quarterly, and at each meeting we review the action plan and make sure that all stakeholders are accountable, and we continue to work on that as we go. In terms of accountability, so we'll be reporting the strategy into the Health Inequalities Delivery Board, and our plan moving forward is that once the strategy is adopted, we'll be undertaking an annual review of the strategy and the action plan alongside that, just to make sure that it remains completely fit for purpose and appropriate for our population. And then at the end of the strategy duration in 2028, we'll be doing a complete refresh and rebrand moving forward into the next period. So in terms of our next steps, we've been continually taking into account feedback, reviewing and revisiting the strategy and action plan to make it as strong as possible. Whilst we've been going through the democratic process, we have already begun work on some of them work streams that are highlighted. So we're just continuing to mobilise them and gain momentum. The next stop for this paper and the strategy is executive in February, and then after that, we're hoping that the strategy will become fully adopted by spring 2023. So just to conclude, the recommendations that I highlighted in the circulated report were firstly for scrutiny to review and provide any feedback on the strategy as it stands, and obviously to provide some continued support and direction so we can help develop and adopt the strategy moving forward as an evolving piece of work. So I'll stop sharing there and happy to take any questions or comments.
Thank you. Does anyone have any questions or comments? Yes.
I think that's excellent. In my other job, I'm a teacher at Luton Sixth Form College, and I find the number of students that smoke tobacco is really reduced. However, I'm really quite surprised at how many students are vaping. You know, quite a lot who've never smoked tobacco are vaping, and I wonder if there's a place for some education in schools. Also, in the rise in the number of smoking shisha, and the fact that people don't realise that there are dangers of that, often because it's a fruit flavoured or something, that they actually don't realise that there is, dangers of smoking shisha, and whether that's an area of health promotion with young people who are tending to smoke less tobacco.
Thank you. And if I can come in there, one thing we are really keen to do is work with our secondary schools and our education providers to make sure that we are supporting their curriculum messages around drugs, alcohol, illicit products. But I think, as you rightly say, this is becoming a bit more of an emerging theme that we're seeing, especially around vaping and illicit vapes. So we have actually got planned a campaign to work directly with our young people that will take place over social media and other outlets designed to really target them. And it is really trying to become an education-based campaign, what to look out for, particularly with illegal products, including shisha. So yeah, we do definitely have plans in the pipeline for that, and really see that as one of our top priorities to achieve within the first year of the strategy.
Thank you.
Thanks, Serena. That was a really comprehensive report. I was basically saying something similar along the lines of what Pat's saying. I think there needs to be a really big focus on education, not just for prevention for young people, but even for adults. So adults from the minority ethnic backgrounds, where having education sessions, even if it's like a workshop or 1 hour drop-in session where you just give a presentation on the risks of smoking, and tailoring that to the different communities, so that the Eastern European communities where smoking is much more prevalent, some of our communities might not be as well educated, so might not understand the risks as much. So I feel like education really needs to be at the forefront of this strategy, whether it's through Zoom workshops or face-to-face workshops. And I know it's obviously something you've considered, but I think it's so important, especially for young people as well, because as we said, vaping has increased so much in young people, and people don't understand the harms. And more recently, I've been seeing like TikTok videos where young people have been admitted to A&E, or they've been admitted with lung failure and things like that just from vaping, and people don't really understand that that can happen from vaping. So there's the education for prevention, but also for the people that are already smoking, and letting them know that if they stop smoking now, in 10 years' time, their lung is almost similar to someone who's never smoked before. So things like that. So yeah, I think education would be great, and doing the education, if we do education in different languages, so people from different backgrounds can understand, and just tailoring it to the different ethnic groups. Thank you.
Thank you. If I can just come back, totally agree. We are working really closely with Total Wellbeing, our current stop smoking provider, who do a number of outreach events already in the community and stop smoking clinics. But one of our things that we are looking at is actually making sure that they are firstly in accessible locations, they're really accessible to the communities, and they are starting to become more tailored and doing bespoke sessions for different groups. So hopefully we will definitely be addressing that. So hopefully, yeah, that puts your mind at ease. It's also at the forefront of our minds too.
Thank you, Chair. Just a comment. Years ago, we had a policy to stop staff and councillors from smoking outside the building, the front of the building. But up to date, there is several councillors up now that will stand outside, right outside the front of the building, smoking. It's not showing a good policy. If this councillor is trying to stop people from smoking, where councillors are standing outside the building smoking. And I think we need to enforce this a little bit stronger. Thank you, Chair.
Thank you. Just have a couple of things. The slide deck you've just shown, that's looks like to be a summary of Appendix A. Would it be possible for you to share the slide deck with the committee?
Yes, no problem.
Thank you. I think my only other question is the graph of tobacco use, where it shows a steep fall in 2050. Do we have any reason why? Do we know why that was? And is it possible that you could repeat what happened then to get that sort of reduction in smoking?
I'm afraid I don't have the answer right now, but it's definitely something I can take away and come back with, if that's okay. As you can see, ours is quite erratic compared to others, and there are potentially sometimes data anomalies in the way things are recorded, but there might be a reason, and I can try and find out and come back if that's okay.
Yeah, that's fine. Yeah. And my other question is there any other examples of local authorities who have done this successfully that we can take advantage of?
Yes, so we work quite closely with our regional colleagues, especially in Bedfordshire, who are also on the same journey of starting to develop their own strategies, and have done multiple different pieces of work around all the different types of work streams that we're also looking into. So we are linked really closely into that regional group, but have also made contact with other partners such as Sheffield, have a really strong smoke-free alliance, and other colleagues dotted around the whole country. But there is a really strong network of individuals working on tobacco control, which we are strongly linked into. So we're continually taking learning from them, understanding best practice and reviewing what's worked well and what hasn't. So Sheffield is one that immediately springs to mind that we've worked closely with and done quite a review of what they've done. But yeah, we're not alone in our efforts towards tobacco control. So have lots of allies to lean on and learn from.
Okay, thank you. Anyone else?
Thank you. I just wanted to come back in on a couple of the points that have been raised. So on the trends, I think up until around 2015, there was a lot of policy changes coming in and national attention on tobacco. So the smoke-free legislation came in 2012, I think. No, 2006, sorry. And that had a big impact for a long time nationally and for all areas, and the stop smoking services had a lot of attention. And I think what's been happening is that the more of the low hanging fruit and it's just getting harder. The people that are smoking now are more sort of entrenched in smoking behaviours, and in Luton we have that population churn that we know about, and high rates of deprivation, which we know is linked to smoking rates. So we have particular challenges in Luton around some of this. But I think a lot of the slowdown of the decline of smoking prevalence is to do with it's just getting harder. So we need to not necessarily do the same as we were doing in 2015, but think about what more can we be doing now that it's that bit harder, and a lot of people have quit that were going to quit. So it's a challenging area, but I think it's not a simple picture. And then I just wondered if Serena, if you wanted to come in on the point around the policy in council sites, because I know that's part of the work, isn't it? And you didn't respond to that point.
Yes, I'll come in if that's okay. So yeah, we are undertaking a review of the current council smoke-free policy, taking into consideration some of the comments and behaviours that we have been seeing kind of throughout the town centre and outside council buildings. So we've started already engaging with HR about how we redraft that and work really closely to make sure that we're sending a really strong message of how to be set the best example as council staff or councillors. So we've already engaged with HR on how we can do that, and also starting to engage with the trade unions about their opinion of how we can really strengthen the policy moving forward. I think it's a bit of work around the policy, but actually doing some more communication with staff across the board and what the expectations are and kind of the grey areas potentially of that policy. So it is a large piece of work that is in progress at the moment, just to really try and crack down on that.
Okay, thank you. Anyone else? Okay, thank you very much.
Thank you.
Okay, if we move on to agenda item number 9, mental health strategy. Nicola?
That's right. Hello. Thank you for having me. I'm Nicola Ainsworth, one of the consultants in public health in the council. Hopefully you agree with me that improving mental health in Luton's a really important issue and will help us to deliver on one of the main 2040 priorities, so improving population wellbeing, tackling health inequalities, enabling everyone to live a good quality of life and reach their full potential. So this strategy has been developed with partners
You've got a strategy, a plan on a page, and an action plan in your pack. If we focus in on the strategy itself, the main aim was to make it as short and accessible as possible. So it has 4 sections to it. First one being, why do we need a mental health strategy in Luton? Hopefully the facts and figures we've given in the infographic show why it's important to have it here in Luton and not just rely on the Bedfordshire, Luton and Milton Keynes 10-year plan, although this does align with that plan. Section 2 is about where we want to get to, what the key principles and the vision are, and shows that we have 2 main priorities within the strategy, which are prevention and access, with 3 underpinning themes of integration, quality and experience. How we're going to get there is in section 3, which is really the action plan, the separate document, and then what success, section 4 is what success should look like. And I've also included the governance structure, and I'd really welcome comments and thoughts on this from the group. Thank you.
Thank you. Just before I throw it open, what is the IAPT?
IAPT. Sorry if that's not explained. That's access to psychological therapies. That's IAPT.
Saying, so in the infographic, it's talking about health needs assessment identified that GPs initially give medication for depression rather than refer patients to. Okay, thank you.
It was just to add to that, IAPT, it stands for Improved Access to Psychological Therapies, and it was brought in quite a few years ago, but it was really around, so it's referred from primary care, and it's really about that lower level mental health, and it was a national drive to increase the availability of those low level psychological services. So it's a referral from primary care into that.
Thank you. Okay, so does anyone have any questions, comments, feedback? Okay. I think I have a few questions. But we're talking about prevention and access. So we're talking about first point of access, and is so how can you talk us how that happens? If someone does how someone who, say, for example, has depression, how do they access their mental health services? I mean, is it a case of getting an appointment with a GP? And
I think that's the usual route. Yes. But one thing we're saying in this strategy is about having no wrong door. So if you present somewhere else, say, for instance, if you maybe have drug and alcohol issues as well, and it becomes apparent that you have mental health issues, they should be able to help refer you into the right place. They shouldn't turn you away. They should help refer you into the right part of the system, or the right part of the service for you.
okay, so my understanding is that so it doesn't matter which route you take. Everyone who comes into contact, who potentially comes into contact with a patient, should know who or where to refer that patient to.
Yes, that's what we're aiming
so
for.
Is that the general thrust of the access strategy? Right.
Yeah.
Okay.
Yeah.
So do we know what proportion of the population experience mental health problems? And you've got a lot of data here. I can't actually see anywhere which says in Luton there's a certain percentage of people who have mental health problems. because you're talking about the stigma of mental health and people not reporting. So presumably there's a proportion of the population who have mental health problems, but we're not aware of.
Thank you for pointing that out. We'll make sure that that's added in, the proportion. I mean, often the statistic of 1 in 4 is used for the general population will experience some kind of mental health difficulty at some stage in their lives.
Do we know if there's any, if Luton is at variance? Is there anything about Luton that makes that different?
Sorry, Sally, did you want to
I was
come
just
in?
going to add, sorry, thank you. So this infographic that is in the strategy is an attempt to pull out the really important bits of a longer bit of data analysis where we can pull out the proportion that have severe mental illness, etc. But without, so the idea was we've got a lot of mental health data, but why do we want to be doing something different in Luton? What are our key issues and challenges for us specifically in Luton compared to other areas? So that infographic really does pull out some of those key points to make that hopefully a bit clearer, that what's different for us in Luton that we really need to be tackling through this, rather than show so much data that it's difficult to navigate. But there are potentially is helpful challenge, because actually we can refine that a bit more and pull out the key points around prevalence a bit more in that, I think.
You're asking if we felt as a committee that you needed to have further consultation, further public consultation. What would you propose that public consultation would be?
I have to admit, we haven't talked in detail anywhere about what that would look like. But in particular, going out to people who have mental health problems to see how this resonates with them would be one aspect I'd really like to work with, and also staff within existing services to see what they think of this more broadly. But how we would actually do it, we haven't got to that level of detail, I'll admit. So if you have any comments on how that could be or how you think that should be. I mean, I'm aware that the physical activity strategy is out for public consultation at the moment. We could use a similar model to that. Or whether we take a more roadshow style of meetings with people.
You're talking in document about the experience of, I can't find the phrase at the moment, the experience of people who don't have mental health problems, who don't have the lived experience. Is it trying to tackle that part of the population who doesn't have that perception of mental health as an issue? Is there any work that could be done in finding out that sort of information about those sorts of attitudes and how to tackle those sorts of attitudes?
Yes, we can definitely look into that further. I think there is research out there that shows they're the people who you need to tackle the idea of stigma with. And that there is research available on that and how to do that. There is evidence available, yes. Yeah.
I think that's about it from me. Yeah.
One question about the complaints procedure. Can you make it simpler and easier for the people to make the complaints?
Oh, that's an area we hadn't thought about at all, actually. So is that something that's been raised that's a difficulty? Yeah.
The people, the patients don't get I know the Health Watch is some kind of safeguarding, but I think if you can actually include this in action plan as well, so the providers can understand, the complaint procedures are very clear, and that's easier to actually make the complaints and the actions taken
Sure.
sooner. Yeah.
Yeah, we'll definitely can include that in the action plan. Thank you. Yeah.
Okay. Right. So recommendations are that we make comments appropriate to support the draft strategy, including the main priorities, that the proposed plan on the page and action plan be supported. I think we can do both of those. And I think we've spoken about public consultation. So if there's nothing else.
Sorry, can I just make a comment? Because Health Watch is an organisation that takes the patient's view, but it's not a complaints department. That would be through other measures that people make complaints. Yeah.
Thank you. Thanks. Yeah. Thank you. Okay. Thank you very much, Nicola. Thank you. We move on to item 10. Primary care access in Luton, and I think this is Amanda.
Sorry, Chair. Maybe I misunderstood. The recommendations are 3, 4, 5. Yeah, in the last item. So can you make some amended about the complaints in that recommendation? Or you can't?
So can you clarify what?
So on page 71, recommendation 3, that the committee review, make comments as appropriate and support the draft strategy. So I just actually explained that if they can incorporate the complaints procedure in the action plan. So if you can actually maybe 0.6 or something you can add in that, or
that's
about
fine.
that, or is that it?
We can amend the action plan. That's fine. Yeah, no problem.
Yeah.
So that's my suggestion.
Yeah, that's it's understood. Yes. Yeah.
So what is the wording then?